Meso-rectal excision, often referred to as total meso-rectal excision, TME, or partial meso-rectal excision, PME, is a precise surgical technique primarily used in the treatment of rectal cancer. This procedure focuses on the complete removal of the mesorectum, a fatty tissue envelope surrounding the rectum that contains lymph nodes, blood vessels, and connective tissue, while preserving surrounding structures to minimize complications. Below is a detailed explanation of the technique. Objective of meso-rectal excision: to achieve complete oncologic resection with clear circumferential margins, to reduce local recurrence rates by removing the mesorectum, which is a common site of cancer spread, to preserve autonomic nerves, maintaining urinary and sexual function. Preoperative considerations. 1. Patient evaluation. Comprehensive imaging, e.g. MRI pelvis, CT scans, to assess tumor location, size, and potential spread. Colonoscopy for visualization and biopsy confirmation. Preoperative staging to decide between neoadjuvant therapy and surgery. 2. Neoadjuvant therapy. For advanced or locally invasive tumors, chemoradiotherapy may precede surgery to downstage the tumor. 3. Bowel preparation and antibiotics. Mechanical bowel preparation and prophylactic antibiotics are standard to reduce the risk of infection. Surgical technique. 1. Positioning and access. The patient is positioned in lithotomy or modified lithotomy. Access can be open, laparotomy, or minimally invasive, laparoscopic or robotic. 2. Dissection principles. The mesorectum is carefully mobilized within its embryological planes. Key anatomical landmarks are identified, such as the sacral promontory, autonomic nerve plexuses, and pelvic sidewalls. 3. High ligation of the inferior mesenteric artery, IMA. Ligation at the origin, high ligation, or distal to the left colic artery, low ligation, to ensure adequate lymphadenectomy and blood supply. 4. Mobilization of the sigmoid and descending colon. The sigmoid colon and descending colon are mobilized to ensure sufficient length for a tension-free anastomosis. 5. Dissection of the rectum, for TME. The dissection proceeds circumferentially around the rectum down to the level of the levator ani muscles, ensuring the entire mesorectum is removed. For PME, only the mesorectum up to 5 centimeters below the tumor is excised, typically for upper rectal tumors. 6. Ensuring a clear circumferential resection margin, CRM. Precision in dissection avoids entering the mesorectum or the tumor plane, preventing tumor spillage or residual disease. 7. Pelvic floor and nerve preservation. The autonomic pelvic nerves, hypogastric nerves, and pelvic splanchnic nerves are preserved to minimize functional complications. 8. Specimen retrieval and anastomosis. The rectum and mesorectum are removed through an abdominal or transanal route. For low rectal cancers, a coloanal anastomosis or permanent colostomy may be required. Intraoperative pathology, frozen section, may confirm margins. Postoperative considerations. 1. Pathological assessment. Examination of the specimen confirms whether the mesorectal excision is intact and CRM is clear. Tumor staging and lymph node analysis determine the need for adjuvant therapy. 2. Complications to monitor. Anastomotic leak, pelvic infection or abscess formation, bowel dysfunction, e.g. low anterior resection syndrome, urinary or sexual dysfunction due to nerve injury. 3. Rehabilitation, early ambulation and nutritional support, long-term follow-up for recurrence or metastasis. Advantages of mesorectal excision: drastically reduces local recurrence rates, improves long-term survival, preserves pelvic autonomic nerves and reduces functional impairments. Challenges and innovations: minimally invasive techniques. Laparoscopic and robotic approaches have been increasingly adopted for better visualization, precision, and reduced morbidity. Learning curve: TME requires significant surgical expertise, particularly in minimally invasive methods. Intraoperative technology, use of fluorescence imaging and advanced stapling devices enhances surgical accuracy. Outcomes: TME is now considered the gold standard for mid and low rectal cancer surgery. Studies show local recurrence rates as low as 5%, with 5-year survival rates ranging from 60% to 80%, depending on tumor stage. By adhering to the principles of precise dissection and adequate resection margins, mesorectal excision has revolutionized rectal cancer treatment, setting a benchmark in surgical oncology.